Dr. Ramirez-Castaneda is a board-certified neurologist and movement disorder specialist at Methodist Physicians Neurosurgery and Neurology Specialists. Dr. Ramirez-Castaneda received his medical degree from Pontifical Catholic University of Ecuador in Quito in 2004. He completed his residency and fellowship at Baylor College and has remained in Texas. Thank you so much for joining us today. I had the pleasure of meeting him when we were in San Antonio, and I was like, please do this program. And he's just lovely. And he said, of course. And so we're so grateful he's here today. Thank you, Dr. Ramirez-Castaneda.
Oh, thank you so much, Aiden. It's a pleasure for me to be here today. So happy to talk about Parkinson's, whether it's causes of Parkinson's, symptoms, treatment, or anything that is upcoming. So this time, I'm going to talk about medication options, and I tried to do a little bit of a comprehensive review of all the medications that are currently available, and I'm going to try to present them in a way that they are organized by type of medications, and I will provide some major specifications and tips about that specific group of medications and things that might be important in understanding as we deal with the complexity of what it is treating Parkinson's disease. So thank you very much, everybody, for joining us. So here in San Antonio, Texas, is very warm, and you know it's pretty. The summer is hitting us pretty strong. So let's move forward, and then if you have questions or anything, please save them or write them in the chat, and I'll be happy to answer them at the end. Hopefully we'll have plenty of time to do that. So I've titled the presentation Medication Options for Parkinson's Symptoms, A to Z review. So before talking about medications, I think it's very important to take into account certain specific characteristics or points that we need to take into account. Selecting a medication for Parkinson's is not as easy as giving the diagnosis and then starting whatever thing that comes to mind. There is a lot of complexities and a lot of thought into what would be the best medication that I could give to this specific person, because again, as most of you have probably already realized, it's not that one direction, one recipe fits all. Everybody has different circumstances and conditions and factors that will make us healthcare providers choose the best possible medication or combination of medications for you. So one of the things is that we have to remember that as it is now, we classify Parkinson's basically on this group of symptoms that fit certain specific standard that we're looking for, and then we clinically give the diagnosis of Parkinson's. Of course, in rare situations, we may have people who we can actually do a genetic confirmation of the condition, or we might have additional testing that might have excluded certain things and may have a little bit more of an objective diagnosis. But for the most part, people get diagnosed based on clinical findings, and that's expected. That's what happens. So that you have to realize that we're clumping together a group of a condition that may have different causes, different origins. And that's why in certain situations, some people may respond better to certain group of medications than others. That's why certain people may have more propensity to develop side effects than others. It's just because the causes of Parkinson's are multiple, and that affects that. The other thing is the age of onset and when the symptoms start to occur. If in people who develop it earlier, such as young onset Parkinson's patients, their evolution of symptoms is a little bit faster. So maybe the medications that we use tend to be a little bit stronger, or we sometimes directly start with levodopa rather than going on other medications. It's just because the type of symptom control that we want to have. How long has somebody had the condition before it's diagnosed and maybe treated also affects that, because expectation would be the longer somebody has had the condition or the diagnosis, maybe the symptoms are more severe, they're stronger, more manifested. Therefore, medications that we would choose for that will have to be medications that have a little bit more of a broad coverage of the symptoms of Parkinson's. The other thing that we take into account is age. Not everybody tolerates the medications the same way. So one type of arbitrary cutoff that we do is 70 years old. So people younger than 70 and people older than 70. And that, in our head, allows us to stay away from certain medications and consider others. One of those is, for example, the group of the dopamine agonist medications, things like propinerol, pramipexole. Those type of medications may not be a great idea starting on somebody older than 70 because the likelihood of developing side effects may be higher. So that's one example. Some other factors that we need to take into consideration are also, what type of Parkinson's do you have? We have two major types of clinical Parkinson's. One is the one that has the tremor, and that one tends to be the more typical, the more common. Maybe we could say 2/3 of people with Parkinson's have the tremor predominant Parkinson's. And in that situation, because tremor might be the main symptom, it will make us choose certain group of medications rather than others. And then the other type is the postural instability and gait disorder type of Parkinson's. So that one, maybe a third of people with Parkinson's will have that. And in this situation, these people do not have tremor. A lot of the times, maybe even the diagnosis of Parkinson's hasn't been that clear. Maybe there have been considerations of maybe this being maybe a Parkinson's plus syndrome or something else. So these patients may have a little bit of a faster progression, lack of response to typical medications. So in that case, the medications that we use a lot of the times end up being, we tried several, and we might even titrate or increase doses in a way that we probably wouldn't have done in somebody with just the tremor type of Parkinson's. So type of Parkinson's is also important to choose medications. Associated symptoms. A lot of the times when we make the diagnosis of Parkinson's and we try to look for what medication would be the best, we have to take into account what other non-motor symptoms or what other medical conditions are on board, because we have to see if the potential side effects of the medication we choose will exacerbate or will help with those additional symptoms. So, for example, if we have already somebody that has low blood pressure as a underlying condition, or maybe because of a non-motor symptom of Parkinson's, like orthostatic hypotension. So we are going to be very careful in choosing medications that we do not increase the dose, or we do it we control it closely. One of the medications that we're going to talk about, like the injectable apomorphine or Apokine, that's a medication that it's pretty effective in controlling symptoms, but the reason that is effective is because the medication injected subcutaneously can go pretty fast into your system. And the good thing is that it helps with symptoms right away. The downside may be that it can cause side effects like lowering your blood pressure. So again, more factors that always plays a role into how we choose medications that we prescribed. Another thing that we pay attention to is, especially when we in specialized centers, when we get referrals from people that have already seen several neurologists and they've tried a lot of medications, people come and most of the times is, okay, doctor, nothing helps. Everything's been tried and nothing helps. And then, it's a matter of really going into that list seeing what medications have been tried. Hopefully we have an idea what doses, how it was titrated, how was it increased, because a lot of the times in these situations, we find some issues with the way that it was started. Maybe there wasn't enough time, maybe there was something else going on that contributed to that side effect that probably was coincidental or wrongly attributed to these medications. So a lot of time we can pick from those old medications. So I never really exclude permanently any type of medications that have not worked in the past, unless it has, I have seen it and I have evaluated and I've been part of it, because a lot of the times, you know, again, we don't necessarily think that all the medication trials are done appropriately. Current medications, you know, we don't want to have interactions. We always pay attention to it, and we're going to get into that, especially with a group of medications that we call boosters. Accessibility and insurance. I mean, it shouldn't be an issue. It shouldn't be a thing that plays in the role of what we prescribe, but sadly it is the case. So especially, you know, when we're talking about newer medications, brand medications, we're so excited. It shows the data that they're better at certain things and less side effects and whatnot. But eventually, you know, once we're there and prescribing, insurance doesn't approve, doesn't cover it, or maybe the copay is too high, and we deal with all those things. So a lot of the times that is gonna plays a role into what we may choose, because sometimes we want to do something rather sooner than later. Support system, you know, it's another way, because if we, for example, are trying to eventually prescribe more of the advanced therapies like enteral levodopa, such as duopa, or some of the subcutaneous therapies, in a person that might have a lot of physical limitations and not have the assistance of somebody else, at least at the beginning, to go through that, it may not be a good idea. It may not be an option. Location, you know, one of the most obvious here is, for example, what's happening in Europe and what's happening here in the US. There's a lot of treatments and things that are already available there, and then a lot of the times we get it years later down here. So it depends where you are, and we consider what we prescribe. And then lastly, but very importantly, situations like ethnical background, culture, language, and all of those sometimes can create some barriers to access. I mean, there is a lot of disparities in the access, especially to advanced therapies in the world of Parkinson's. In a lot of places, really the access to things like deep brain stimulation, for example, does not translate into what the proportions ethnically or racially in that specific place or location are. So there's a lot of things that are going on in that aspect too. So again, this kind of I wanted to just bring to your attention, because it is a little bit, it's not that simple, and it's not that we have option number 1, 2, 3, and then we send it and we apply the same thing for everybody. There's multiple factors that makes the decision on what to prescribe a very, very customized and a specific thing for each individual. So let's start with A to Z. I mean, I didn't organize them from A to Z, but I organized them by groups. And the main group in the treatment of motor symptoms, again, those are what comprehends the tremor, the slowness or bradykinesia that we call medically, the rigidity or stiffness. So the medications that treat those motor symptoms, the main group is the oral dopaminergic medications. So basically means that these are medications that act on the dopamine system, basically activating those dopamine receptors. So we have two groups, the dopamine agonists, which are medications who are a little bit more selective or specific. There's multiple types of dopamine receptors. Dopamine agonists act specifically on the ones that have to do with motor control. The main representatives of this group of medications are medications that have been available for a long time. Ropinirole with the brand name Requip. Those we have immediate and extended release forms. pramipexole with the brand name Mirapex. On that one, we also have immediate release and extended release forms. And then we have the transdermal patch, rotigotine or Nupro patch that are available. So those are the three that we have available here in the United States. In regards to the levodopa containing medications, we have different types of presentations, but the difference on levodopa is that levodopa acts on all those dopamine receptors, so it's not as selective. Therefore, with levodopa, the expectation is that we have a stronger benefit, and it may also go beyond just the motor symptoms. Sometimes we have also expectations that it may help with mood, with cognition, with speech. I mean, it's just because of the fact that levodopa acts in all those dopamine receptors. And as you can see there in the list, we have different forms. We have immediate release forms, we have extended release, continuous release. We used to have the disintegrating form Parcopa that was taken off the market. We have a combination of carbidopa, levodopa with entacapone, Stalevo, and then kind of one of the, although not that new, but one of the most recent ones, which is the combination of immediate release and extended release on the same capsule, which is Rytary. And the last one that came out, which is carbidopa, levodopa, but we have the ability of breaking this tablet in quarters. So for people that really are very susceptible for small dose changes, having this type of tablet really allows us to be very, very specific. And, you know, just to clarify, you know, when we talk about carbidopa / levodopa, have to remind you that the second compound, the levodopa, is the active part. That's the one that is going to be absorbed and eventually pass inside the brain, and then it becomes dopamine. Carbidopa is an added compound that we put just to decrease the transformation of levodopa to dopamine in the periphery, in the blood, because if that happens, if we just gave you levodopa without carbidopa, the side effects that you would experience will be very intolerable, and those would be nausea, lightheadedness, low blood pressure. So that is the reason why it's always carbidopa, levodopa being the active compound. So a few pearls or tips or pieces of information in regards to this medication. So when we talk about dopamine agonists, so here on the left side of my slide, when we're talking about levodopa, here on the left side of my slide, we have to remember that levodopa only has a half-life of 1 hour. So once the medication is absorbed, it lasts only for 1 hour in the bloodstream. So and as it goes to the brain as well. So that's why when we take the medication, the levels go up, and then within an hour they're already start to come down. Why do people take 3 times a day or every 6 hours, especially at the beginning? Because remember that you still have your own dopamine. You're still producing dopamine. Therefore, you don't depend completely just on the medication. We're just giving you additional levels of dopamine, so your own dopamine can help you with those symptoms until the dose goes down and up. So that's why, although it has only 1 hour of half-life, the levodopa, because you're still producing some dopamine, it still sustains that. And that's also the reason why over time, as your own production of dopamine decreases, you become more and more dependent on the half-life of the medication. And that's why a lot of times people that only take carbidopa, levodopa, and haven't tried anything else, the only way that it works is if they're taking it every hour and a half or every 2 hours, because at that point, they're completely dependent on the half-life of the medication. The other important thing is that the absorption of carbidopa, levodopa is very closely related to the food intake and your gut motility. So that's why, in general, we recommend people not to take the medication right with the meal, but maybe 30 minutes before or 30 minutes after having the meal. That way, the bolus that is created inside your gut doesn't capture the pill and doesn't decrease or blocks the absorption, because it's just all inside that, and once it bypasses that small intestine, it cannot be absorbed anymore. The other thing is that gut motility is a very big factor, meaning the peristalsis, the movement of the gut that allows everything that we eat to kind of come one way and eventually get out the other way. So people with Parkinson's do have motility issues. Up to 80% of people with Parkinson's may have these issues. So if the medication is staying longer in your stomach and is not emptying into the small intestine, that's why people may see issues such as the medication is not kicking in on time. Why is it taking so long to get the benefit, and things like that. So people who start these medications, we have to discuss and put a lot of, devote at least certain amount of time to talk about these things, because it's good to learn this from the beginning and know that, you know, if I'm not supposed to take my medication with meals, I have to maybe make it a little bit earlier or later. If I'm having issues that maybe my stomach, especially people with diabetes, the motility of the stomach is even slower. We have to take into consideration those type of things to compensate and make sure that the medication is absorbed better. And what I said earlier is that also levodopa acts in all the dopamine receptors, therefore the benefit, the effect tends to be a little bit strong. Now, on the right side of this slide are the characteristics of the dopamine agonists, things like ropinirole, pramipexole, rotigotine. So the half-life of those is longer, say 6 to 8 hours in the case of ropinirole and pramipexole, and almost 20, 24 hours in the case of the Nupro patch. So they stay in your system longer. So you would say, oh wow, so that right there makes them better. Why are they not as effective as levodopa? Again, is because of the fact that they act only on certain group of receptors rather than all the dopamine receptors. And the other thing is that because they last longer in your system, they tend to cause more side effects, and especially if you develop a side effect, it takes longer to go away or to improve. So the type of side effects that we tend to see more often in people with dopamine agonist medications are sleepiness, impulsivity issues. Sometimes can get to the point of really spending a lot of money, gambling, hypersexuality, and things like that, and hallucinations. And again, the likelihood of why these are more common in this group than the other is just because they last longer in your system. So again, like many other things, sometimes good things in regards to something, in control of symptoms and less wearing off, I guess. But on the contrary, if we have side effects, then they last longer. All right, so now let's go to the next group, which are the anticholinergic medications. Anticholinergic medications were used more often and in higher doses in the past, but nowadays, since we have many other groups of medications, the use of these are less common. Usually, these medications are utilized in people with milder type of symptoms, and especially the ones where the tremor, the rigidity is not well controlled just with the levodopa or the dopamine agonist. So we have medications such as trihexyphenidyl or Artane, brand name. We have benztropine or Cogentin, which is the brand name, and we also have amantadine that has an anticholinergic effect. We're going to talk amantadine also a little bit later in the group of anti-dyskinesia medications, but right now I'm clamping it here. I'm putting it here because it also has this anticholinergic effect, and that's why maybe for most of you, probably you were started on amantadine when your Parkinson's symptoms started, because of that anticholinergic effect that is good at controlling some of the tremor, some of the slowness. What things do we need to take into account on these medications? what I was mentioning, that they can help with tremor rigidity. However, they don't do much for bradykinesia or the slowness. The main medications that help with the slowness are the medications that act on the dopamine system, such as levodopa or the dopamine agonist. The anticholinergics are not good at helping with it, but they might help with tremor and rigidity. The thing is that a substantial percent of people that take this medication, sometimes it feels that is 40–50% of people, may develop these very uncomfortable side effects that are related with the fact that they are anticholinergic. So things like cognitive slowing or cognitive clouding, blurry vision, dry mouth, constipation, urinary retention. And somebody with Parkinson's may already have all of this, and having the risk of giving something that might actually make that worse really doesn't sound like a good idea. And this is one of those medications that when I was telling you in my initial slides on all the considerations, as far as age, an anticholinergic wouldn't be a medication that I would be excited or to recommend in somebody 70 years or older. You know, I would only reserve this for younger patients that don't have any of those issues or side effects or non-motor symptoms already, and that the symptoms are relatively mild, because otherwise trying to use this as a new medication in somebody 70 or older is very likely that they will end up with those side effects. That doesn't mean that if you are in that group, age group, and you are on it and you are tolerating it and it's helping, I mean, if it works, we leave it there and we just track. I mean, also don't think that if you are on it just because you're older than 70, you should discontinue the medication, because if it helps, and I have a lot of people who have been on these medications for all their condition, and I have tried to lower the dose or take it away because I was concerned about potentially having side effects, and as I tried to take it away, some of the symptoms came back, so they were better off with the medication. So again, everything depends on that specific situation of each single individual. And then, you know, with these anticholinergics, again, the summary is that older equals more side effects. So that's why if it's something that we are choosing and what to start, I would stay away from this in somebody older than 70. All right, let's move to the next group. And those are I call them the boosters. And these are medications that some of them have been around for a long time. And for each one of these categories, more recently, over the past few years, newer compounds have been launched into the market. So that's great. It increases our options and ability of where to choose from. So the first group is the monoamine oxidase type B inhibitor, or MAO inhibitor. One of the oldest medications that we use for this, you know, is rasagiline, brand name Azilect. We have selegiline, and we have one of the newer ones that came over the past 3-4 years, safenamide, or brand name Xadago. So this group of medications, I'm going to give you a little bit more of details, but let me touch base on the other group, which is the COMT inhibitors. Is the catecholamine transaminase inhibitors, and these are medications also that have been around, especially the entacapone, for a long time. And again, over the last 3-4 years, an extended release form came to the market called opicapone or Ongentys. So these medications, there are some considerations that we have to have. So for the monoamine oxidase B inhibitors, so the MAO inhibitors, things like rasagiline, selegiline, safenamide, what they do, they increase up to 20% the effectiveness of levodopa. So in people who they are noticing that wearing off, maybe they have this 30 minutes, an hour of off time before the next dose, maybe the on time is not good enough. Something like that might be a good option, because it kind of gives that extra thrust, that extra boost to the levodopa that you are already taking. Also, it doesn't only increase the strength or effectiveness of the levodopa that you are taking per mouth, but it also helps to the dopamine that you are producing in your brain. So that's why sometimes in people who have very mild symptoms, we may only prescribe MAO inhibitors, something like rasagiline, for example, and that might be helpful for a few months or a few years. So that also is a possibility. The thing about these medications also, the good thing is that they can be dosed once a day, most of them. So that's very convenient. We don't have to be taking it every single time. With the selegiline, that is dosed twice a day. And selegiline is particular because one of the products of degradation, of metabolism of selegiline has an amphetamine-like effect, which sometimes we use to our benefit when we have some people that have a little bit of issues with somnolence, sleepiness. So we use it a little bit as a stimulant. So if somebody is needing that extra booster to increase the strength of the levodopa, but at the same time they're struggling with being somnolent, so something like selegiline might be a good option. And then the other thing is that with this group of medications, these are the main reason why, every time that you go to the drugstore and you want to buy any over-the-counters, most of these especially cold medications, they have those big letters, do not take if you have Parkinson's, or talk with your physician if you're going to use it. It's because the assumption is that people with Parkinson's might be on these MAO inhibitors, and these are the ones that we have to be specific with certain group of medications. So the main ones that you might be exposed to or have the likelihood of being on are the antihistaminics. So these are kind of things like Benadryl, Claritin, and things like that. And a lot of those cough medications when you have flu, or you're feeling you're having any upper respiratory symptoms, especially the ones that say PM, the reason that those have that ability of helping sleep is because they have an antihistaminic, something like Benadryl, for example. So those medications plus the MAO inhibitors may have a potentiating factor in bringing down your brain function, and may give you somnolence, it depresses the function of the central nervous system and makes you zombie. So in order to avoid that, if you are taking a MAO inhibitor, try to avoid things that have antihistaminics. With antidepressants, we also kind of have to be careful, especially with fluoxetine. So people who are on MAO inhibitors should not be also on fluoxetine because the additive effects and the potential interaction. Pain medications such as tramadol, methadone also don't go well with this medication. Antitussive medications, things to kind of control our cough, such as dextromethorphan, is another one that you shouldn't take if you are taking any of this. Again, rasagiline, selegiline, sulfonamide, and then muscle relaxants such as cyclobenzaprine, which is a common muscle relaxant that people may be. So on these medications, again, the MAO inhibitors, we have to be aware of these. And that's kind of pretty much the only one in all the groups of Parkinson's medications that we really have to pay attention to those other medications that might be on board. Now, in the group of the COMT inhibitors, like entolcapone and opicapone, we have to be aware that when you start taking it, you might see this red color in your sweat and maybe in your urine. So don't be alarmed. It's for some people, it's part of the metabolism, and it may stain light color clothing. So that's something to deal with, but it's not a sign that it's toxic, that you are bleeding, or something bad is happening. As opposed to the rest of Parkinson's medications, which most of them have as a side effect constipation, entolcapone, opicapone is one of the few that may actually do the opposite and may cause diarrhea. So in this situation, it's like one of those factors that I was telling you. We have to consider what else is happening. And maybe if I have a patient that is really dealing with constipation and I'm right now trying to choose what booster do I use, maybe I would choose something like entolcapone, because I would expect that with this, it's not going to worsen the constipation, it may actually help. So, and then the extended release form, the newer one, Ongentys or Opicapone, which is the generic name, because it's a long-standing, and it helps because it can provide more effectiveness. If you develop a side effect, it may be a stronger and longer lasting. So a lot of the times, I have had some patients who really liked it because it helped, but the side effect was too prolonged, too scary, too strong, and they didn't want to try it again. So that's kind of, again, that dual thing with extended release forms. Yeah, it may be more effective, but on the other hand, if you have a side effect, it also can last longer. All right, and then that's kind of one of the newest booster medications that we have on the market. It's called Norians, or istradefylline. It's a different type of medication. We're all very excited because it provides another system, another set of receptors that we can kind of help with increasing the effectiveness of levodopa. And this one works in the adenosine A2A as antagonist. So they have to do with those receptors for nicotine, tobacco, smoking. So we have to take a little bit into consideration if we have a patient, somebody that is really a heavy smoker, the effectiveness of this medication may not be as good, and we may need to really give a much higher dose. So that's kind of one thing to consider. And then the other thing is, as far as the specific different type of side effects that this medication, this newer medication can give, is decreased appetite. And if I have a person with Parkinson's and I'm looking to add something else to improve the symptoms, and that person is already losing weight, is struggling with appetite, of course I'm going to stay away from this. On the other hand, if I have a person that maybe has excessive weight as a problem, maybe obesity, and that's the struggle, and they happen to have Parkinson's, and I want to add a booster, maybe something like this could be. So again, sometimes we use our side effects as a benefit. And then compulsive behaviors, which is kind of one of the other potential side effects that these type of medications can provide. So we have to monitor them closely. All right, let's go to amantadine, which is I had talked about it previously, kind of more as an anticholinergic, and to help with those motor symptoms of rigidity and tremor. But in this group, we're talking about medications that help to control the wiggly involuntary movements, the dyskinesia. So this is an anti-dyskinetic medication. So we've had amantadine for a long time, and as the normal regular release, people dose it twice a day, 3 times a day, in the past even 4 times a day. Most recently, we have extended release forms, which are taking once per day. So Gocovri is taking at bedtime, Osmolex ER is taking early in the morning, but just once per day. And again, this medication, the intention is to bring down those wiggly involuntary movements, dyskinesias, which we all know or should know that these are long-term side effects of the levodopa or these dopaminergic medications. So things that we have to consider on this group of medications, as I said, that they help dyskinesias. The other thing is that the specific type of side effects that they have, and we have to discuss that with our patients, so they're aware. So dizziness tends to be common, more likelihood of having hallucinations. So again, if I have a patient that is already dealing with hallucinations, I'm not going to use this medication. Also, if somebody's having hallucinations and they are on this medication, besides levodopa and other dopaminergic medications, probably this is the first medication that I would lower or discontinue until those hallucinations go away. Ankle swelling, that's kind of a one that is pretty specific of this medication. So kind of it's called peripheral edema. So it's usually in the legs. feet, ankles, sometimes can be all the way to the knee, swelling, accumulation of fluid. It's reversible, doesn't mean that your kidney is being damaged or you're having heart failure or anything like that. It's just kind of one of those side effects that they're scary, uncomfortable, but benign, meaning that once you stop the medication, it goes away. And then the other one is the livedo reticularis, and I put a picture of it there. And it's this kind of blotchiness of redness, like honeycomb, usually in legs, but sometimes it can be in the entire body. Again, it is a transient side effect. If the medication is decreased or discontinued, it goes away. So it's also not a permanent thing. And I've had some patients who, despite this or having, for example, the livedo reticularis, they do get the improvement of the dyskinesia. So a lot of times we have to wait, and if this is not bothersome, is not causing any problems, then we persist or we stay on the medication. The extended release form, one of them, Gocovri, the company that makes the medication did a study. And one of the additional benefits that was found, besides controlling the dyskinesias, the wiggly movements, was that it also provided some improvement as far as decreasing the off time. So that was an additional benefit that wasn't expected, but in this extended release form and in the study, it provides. So a lot of the times, when we are considering lowering dyskinesias and at the same time maybe covering those gaps, maybe the off time, it's increasing, using Gocovri can be of an option. All right, so now so all of the medications that I've talked about until now, they're all medications that are usually scheduled, they have a specific schedule, you have to take one tablet once a day or twice per day or 3 times per day, so you know that you have to take them every day. Now, we have the option of taking on-demand medications, meaning medications that are taken as needed, or PRN. And that's a great thing, because before we didn't have this many options. So the ones that we have available are the inhaled levodopa, or brand name Inbrija, which comes, it's come in these 2 capsules. That is this powder that when you're ready to use, you grab the inhaler, which is there in the picture, and then you put the capsule, you press it, then you perforate, and you take a big inhalation. You wait a few seconds, and then you do the second capsule. So basically, this is levodopa in a powderized form that once you inhale it, it goes all the way to your lung, and then there it's absorbed. So that mode of absorption is faster, it bypasses the stomach, and therefore the benefit is expected to be sooner. Subcutaneous injection of apomorphine or apoquine, that this being around for a long time. Many of you have probably at one point or another used it or still use it. This is an injectable that delivers the dopamine agonist apomorphine directly into your subcutaneous tissue. Therefore, since it's a very vascularized area, it's absorbed faster to the bloodstream and eventually to the brain. So from the 3 on-demand medications, this one tends to be the fastest and the strongest. Sorry, and it does come in this self-administering pen that it's easy to regulate and use. So you can see a picture of somebody self-administering. So the inhaled levodopa, the benefit usually you expect it within 10-15 minutes, because it's this powder that goes into your lung. For some people, it may cause a reactive cough that it may not be a big deal and it may go away, but for a small percent of people, it's bad enough. They don't like the experience, or is recurrent, that they don't want to continue using it. And it does need to know a little bit of learning as far as the technique, but once you do it often enough, it just becomes very simple. But at the beginning, it's a little bit intimidating. You put the capsule, you don't know if it's perforated or not. You don't know really how much really is a good inhale. how much you weigh. So it does take some learning. So kind of that could be kind of one downside. And then the other thing is that be aware that this powder, when it gets wet with our saliva, it oxidizes and it becomes darker. So in some people, it's more obvious than other, and then they may see around their lips, their teeth, their tongue, like this brownish, darkish thing. So you got to be aware that that can happen and not be worried that, oh my God, what is this? Am I bleeding? So talking and warning this to patients is always a good thing. Now with the injectable, I mentioned that is the fastest in acting. Within 5-10 minutes, you can get that good on time and helping with all those motor symptoms. But again, the same thing that I've been telling you with extended release forms, or when they are stronger, because they're faster, they're stronger, that also can give you more side effects. So in this case, the nausea can be a very uncomfortable thing. So in some situations, we pre-medicate, we give an anti-nausea medication prior to giving the injectable. However, people adapt to it, and then if it's something that you've been taking over a period of time, that nausea eventually is very minimal or goes away. The other thing that can be affected as a side effect is blood pressure. So it can lower your blood pressure. So we have to do it very carefully, and then that's why whenever we start this medication, there is a specific protocol where we assess from the smallest dose, we see how it helps. If we take your blood pressure, make sure that it's fine, and then we keep increasing until we get the desired benefit, and making sure that it's not affecting your blood pressure and that your side effects are not a problem. So for this medication, it does need a titration visit that can happen at the healthcare provider's office, or there's a service from the company that they go to your house to do that titration. And that's the one that I usually use for my patients. The other on-demand medication is the newest of the group, and it's a sublingual apomorphine, or Kingmo. This is a sublingual strip. It has different strengths, and then you put it under your tongue, and it's intended to help with your motor symptoms. Same as the inhaler, it takes 10 to 15 minutes to get the benefit, and it depends on what dose you end up choosing, because as you see here in this picture, it starts from 10 milligrams all the way to 30 milligrams. So as you get a titration kit, you will see which one of these is the one that works for you without giving you side effects. So that's kind of what allows you, or makes you choose what strength you get. And then sometimes you gotta sacrifice some of the benefit for some of the side effect that you may get, and may end up with a lower dose. Just because the nausea that gives, it's uncomfortable, because again, nausea can also be one of the side effects in this medication. And with the option of taking anti-nausea medications prior to starting the medication to help with that. And again, the nausea might taper down and go away over time. One of the particular side effects that sometimes we've seen with this medication is that it can give mouth and throat swelling and pain. It's not an allergic reaction, but it can be uncomfortable for some people, and that might be the reason why some people don't continue using it. All right, so then really quickly, just want to mention a few of the medication advanced therapies that we have available and about to be available here in the United States. The one that we have is the enteric levodopa pump, or duopa, which utilizes a pump or a port that is inserted into your stomach and goes to your intestine, and then the medication is delivered through this external pump with the medication in a gel liquid form that goes directly into your intestine, and that is available, and then we use it. However, the next two, the subcutaneous infusion levodopa and the subcutaneous infusion apomorphine, are very close to being available. They're in the final stages of FDA approval. One of them has been already, but there's this just kind of period of time that takes until it can be available. But the objective or the of these medications are that they use the same principle of insulin pumps, where you have this little needle that is attached into your in the subcutaneous tissue, and then you have it, and then with this little pump that provides the medication continuously. The benefits of the medication is that it's being given continuously over a long period of time. So, for example, the duopa or enteric levodopa you connect it early in the morning, you use an entire day with that continuous infusion, and then you turn it off at night. So you basically have these 12 hours of continuous infusion. The subcutaneous levodopa and apomorphine pumps, they can be used just during the day or in a cycle of 24 hours. So it will be dependent on the needs of every individual. The fact that a stoma, a PEG tube, has to be inserted for duopa, the enteric pump, we have to deal with a proceduralist, a gastroenterologist, or a radiologist that will place that. So some of the side effects that people have on this are related to that implantation, but usually don't last more than a few days. And then eventually that stoma heals, and it just is the port that administers the medication. In the subcutaneous infusion pumps, there is this risk of skin irritation, redness, rash, infection, and even abscesses. So for some people, even though it might be very effective, if they have these recurring issues with infection of the skin, and especially the abscesses, and it ends up not being a good option for them. All right, so the objective of my talk was oral medication. So I just put this slide here because if we want to be comprehensive of the things that we have available, there is advanced therapy, and kind of one of these is deep brain stimulation, but I'm not going to go into that. And then really quickly, as we are finishing, I just want to touch some of the non-motor oral medications that are available. For some people, motor symptoms might be very well controlled and not a problem, but then there's all this group of non-motor symptoms that it's very frustrating because sometimes there's no specific medications, or there's no ability of identifying them, or they're just not talked about. So it's always good to remember. So for example, hallucinations can come just as part of the progression of Parkinson's or as a side effect of these dopaminergic medications. So we have this medication pimavanserin, brand name Nuplazid, who is very helpful in controlling this type of hallucinations, psychotic behavior that people with Parkinson's may have. Before Nuplazid, we used to use a lot an antipsychotic like quetiapine or Seroquel. We try to stay away from antipsychotics in Parkinson's because what these antipsychotic medications do, they block dopamine receptors. So we're pretty much doing the opposite of what we want to do with the treatment. But in situations when psychosis, hallucinations are really intense and causing behavioral problems, we have to resort to these medications. And quetiapine is the one that has the least of the dopamine blocking effect. So that's why historically and still to date, we continue using it, but we always have to do it very carefully. Orthostatic hypotension, another non-motor symptom that is challenging and difficult to control, and especially, in areas like here down south during the summer. I know that all my patients with orthostatic hypotension have exacerbations and more issues because just of the heat and the sweating. So it can be pretty problematic. So orthostatic hypotension, again, low blood pressure can be part of Parkinson's. People with Parkinson's do even without medications, the low blood pressure over time lowers, but also the Parkinson's medications, levodopa, tends to lower blood pressure. So there's a double whammy there. So the medication that we have available for that is a medication that is specifically for people with Parkinson's that have low blood pressure. It's called droxidopa, or the brand name Northera. We also use an antidiuretic, such as fluorocortisone or Florinef, and then we use a medication that directly tends to tighten the vessel to kind of help support that blood pressure, which is midodrine. So all these medications have their specific uses, when to use it, how to use it, and at least we have some options that we do. Medication is not the only option in this type of situations. We always start with behavioral changes and generic changes such as drinking plenty of fluids, compressive stockings, salt intake, and many other things. before we resort to medications, but sometimes it can be pretty complicated. The management of depression and anxiety is very important. It's relatively common to have underlying depression and anxiety besides Parkinson's, and we have very low threshold to start medication. So here we have multiple options, medications that inhibit the reuptake of serotonin, or the medications that also act in the norepinephrine system, and then benzodiazepines, especially for the management of anxiety. So in this type of situation, also it just depends on what the person has tried before, what they're on currently, how severe the depression is, how we want to address it, and then there's multiple different options of medications that we can use. And then for cognitive decline, which again, for some people with Parkinson's, maybe one of their non-motor issues, we have some or memory medications that we can use. So in the one group, we have medications like donepezil, rivastigmine, galantamine that can be used, and then on a different group, we have memantine. And in some people, depending on if it truly is just a mild cognitive decline versus a full-blown dementia, we may use one or two of these medications along with other type of approaches that we have. And then the last one is insomnia, very common, non-motor symptoms, sadly, and very challenging. A lot of the times we have to really pay attention to our sleep hygiene, because my approach is usually going to things that can be fixed. I mean, are you watching TV when you're in bed? Are you with your iPad, with your phone, and with that bright light? Are you taking long naps in the day? What are you doing that can be modified before we resort to medication? So things that we have available are things like melatonin that helps with the REM behavior disorder, low dose of clonazepam, and then medications that I mentioned there that, depending on a specific associated other symptoms, we can use it. For example, mirtazapine is a medication that we use for sleep that is very helpful in people that have poor appetite, because it acts as an appetite stimulant. So sometimes we can use it for that purpose as well. People who have restless legs syndrome and they need something to help sleep, gabapentin may be a good option because it helps with the leg restlessness, but it also helps with the sleep. So. And I think that's it. So those are the A to Z. Really, my mouth is dry. I mean, there's quite a bit of medications, but I hope that just kind of gives you an idea that what is it that we have available to treat all the symptoms, not just motor, but motor and non-motor symptoms of Parkinson's. Thank you.
This was wonderful, Dr. Ramirez-Castaneda. You just covered everything. It was wonderful. I did have a couple of questions, though. Somebody asked, because you talked about the half-life. Can you just explain briefly what the half-life is? Sure.
All medications that we take, there is a measurement of the levels in the blood. So they do this correlation with when the medication becomes effective and when that effect goes away. So every single medication that we take has a half-life that we can look it up in that very long list of very tiny print. So that gives us an idea on how often to dose medications. So medications that have short half-life are usually dosed every 3 times a day, 4 times a day. Medications that have longer half-life can be dosed twice a day or once a day. And again, this thing about the short half-life of levodopa is not stressed enough, because a lot of people assume, and I didn't know even until after medical school, how short the half-life of levodopa is, and 50-60 minutes is very short. But the way to understand why is it that then we don't need to take the medication every hour is because, remember that you're still producing your own dopamine in your brain, and that helps cover that gap, at least until the condition, until Parkinson's becomes more advanced stage.
Question. Somebody asked, knowing that protein in the gut is like the enemy to absorption of carbidopa, levodopa, are there foods that can be eaten with the meds to enhance absorption?
It's a very good question, but no, there isn't, and people have looked into that. So if protein decreases the absorption because of competition of absorption, is there anything that may enhance? No, as far as food, but sometimes there are things that can be done to maybe allow the stomach to empty faster and dump the medication into the intestine. So taking a little bit of carbonated water can help, because it helps a little bit to distend the stomach. Then the stomach thinks that it's full, and then it will empty faster. But you got to be careful, because if you already suffer from a lot of discomfort, distension, burping, and things like that, taking carbonated water may not be a good idea. But sometimes I do recommend my patients, if they want to have a little bit of a faster absorption, crush your regular carbidopa, levodopa, and then take it with carbonated water, and that might speed up a little bit the absorption. But remember that if you're taking an extended release medication, you cannot crush it, because otherwise you lose that extended release capability. And then again, since I'm on this, a lot of people sometimes forget, if you are taking the combination immediate release, extended release, Rytary, the one that comes in capsules, if you have difficulty swallowing, it's okay if you open it and then you put those little sprinkles on applesauce. You don't lose the extended release form on that specific medication.
Last question, because we're over, but just it was kind of a clarifying question. Somebody was noticing that they're like, all of these meds are really to treat the symptoms. Is there anything for disease progression at this time, or is it really just to treat symptoms?
Great question. Sadly, so far we don't have anything that we can use it commercially to slow down or cure Parkinson's. Everything that I've presented to you is purely symptomatic, is purely to improve your quality of life, and with or without it, progression remains the same. Right now, the only thing that we have that might make a difference in progression is exercising, and a lot of the times I put more effort and time into making my patients understand this. Yeah, medications are great and everything, it helps the symptoms, but if we really want to have some stability and maybe slow down that progression, daily exercise is something that needs to happen. The fact that we don't have medications doesn't mean that they're not being studied, that there are not a lot of things that are on the works. So it is exciting, and it gives you a lot of hope, because it may be that in the near future we may end up with something. It may not be useful for everybody, but at least it's a starter. So I have my hopes very high that in the near future we'll have something.
Thank you so much, Dr. Ramirez-Castaneda. This was just, like I said, incredible. We have a tradition here at PMD Alliance, our wave of gratitude. We are so grateful for your time today. This was just an excellent presentation. Thank you so much.
Well, you're very welcome. It was a pleasure.